Cretan protocol for contact lens. Cross-linking treatment.
Okay, sure. Yes, thank you, sir. So basically, what I'm going to talk to you about is the CXL plus concept, which is the both Athens and the Cretan protocol to do with cross-linking. We all know that cross-linking has proven itself over now a couple of decades with more than 1,000 published publications in which we have seen that it is very, very successful to stabilize cornea biomechanically, decrease cornea's deformability, and also, of course, to halt the keratoconus progression. Now, let's look at Swati, who was one of our first patients to undergo cross-linking. You can see that she had actually a progressive keratoconus with a relatively low uncorrected visual acuity of 20/100, a reasonable but lower best corrected visual acuity with the spectacles of 20/60, and a thick cornea of 490 micron. She was contact lens intolerant. This is how she looked like after 5 years. You can see this is the pre-operative and this is the post-operative topography, demonstrating not only that there was a topographic stabilization, but in fact there was a slight improvement. So as doctors, we were very, very happy, but Swati was not. And that was mainly because she still had low best corrected visual acuity and she was still contact lens intolerant. So then we realized that many of our post-CXL patients do not achieve good functional vision, especially if they cannot tolerate contact lenses, and that's because of the remnant component of irregular astigmatism. To get over this remnant irregular astigmatism, Kanolopoulos et al. Devised a two-stage approach in which first they did a cross-linking to stabilize keratoconus, and about 1 year of cross-linking they did a topo-guided treatment to regularize the anterior refractive surface so as to improve functional vision. But in this process, they saw that the haze was higher. They were already removing a cross-link cornea. Therefore, Kimionis et al. From our group and again Konolopoulos, both the teams actually published in the same journal, in the same issue, a new approach. Now this is called as the Athens protocol, in which we combine the topography guided PRK along with the cross-linking in the same sitting, so that we can give them the functional vision as well as we can still retain the stability of the cornea with or without the use of mitomycin C. But it is important to note that in this topo-guided PRK, it is not a refractive correction treatment, but it is a therapeutically regularizing module only to improve the functional vision of this patient. So we are not looking at refractive correction. We have to always stay back within the bracket of 40 to 50 microns of ablation and not more than that. Now let us look at this patient who came to us with a topography like this, and then after the Athens protocol, this is the post-operative scan, and you can see a fairly regularized cornea. The patient's vision improved from 6/12 to 6/6 in the post-operative time. Then we went on to do a long-term study in which we compared this PRK CXL, which is the Athens protocol, along with the CXL alone protocol in terms of long-term evaluation to compare visual, refractive, topographic, and in vivo confocal microscopic outcomes. And then we could show in these patients that the refractive outcomes as well as the visual outcomes were significantly better with Athens protocol, here gaining 30 letters on logMAR versus only 8 in Athens protocol, and also in terms of the best corrected visual acuity gaining as much as 8.6 letters, as against at only CXL could get only 4 letters gain. It was seen to be a very, very safe modality of treatment. But now the next question is that many of these patients do not have enough thickness to even do this ablation of 40 microns, which is required in Athens protocol. So what about this moderate keratoconus with even thinner corneas? Therefore, now the next question was that we all know that mechanical removal of corneal epithelium is an essential component of cross-linking, but can we use the epithelial debridement method in itself to improve the visual outcomes of cross-linking methods? We all know that there are a variety of ways in which we remove epithelium in this manner, but there is more insight about this epithelial thickness, which was shown by Dan Reinstein, and we could see that the epithelial pattern in the keratoconus with in this manner is actually not even, but it is thinnest at the apex of the cone. It goes on becoming thicker like annular pattern. So we used this hypothesis in which we actually decided to do a 50 micron PTK. So when we do 50 micron PTK, you are ablating on the thin epithelium, but you are also topping off a bit of underlying stroma so as to give a simulated treatment compared to a topo-guided procedure without using much ablation and without doing a topographic guided treatment. So we showcase this by our first paper which we published, in which you can see again the pre and post operative topography, and you could also see the Bowman ablation which has happened at the apex of the cone. Again, we went on to do a long-term study between this new protocol, which was combination of now PTK and CXL, called as the Cretan protocol, versus only the standard resident protocol in a long-term manner. And in this case, we had 38 eyes which were randomized, and we did TPTK by 50 micron, and we could actually showcase that there was a statistically significantly better outcome when we combined TPTK with CXL rather than doing a mechanical epithelial debridement, which was done in CXL alone, with more lines gain, which was seen in the TPTK CXL group as well. So far we have done 4 long-term publications about this, and recently we have showcased that over 5 years of duration this has shown a very good stable outcome with improved visual analysis. So to conclude, Athens and Cretan protocol both are a good combination of laser along with a therapeutic treatment to improve the functional vision, which is combined with cross-linking to stop the keratoconus from worsening. This can optimize your visual, refractive and topographic outcomes in comparison to CXL alone, and of course in well-selected patients. So thank you very much for your kind attention. Thank you.
Thank you.
Yeah.
You have covered everything in
Yeah.
this topic.
Thank you, sir.
It is
Yeah.
a recent research.
Thank you, sir.